Welcome everyone to today's webinar. I am Mary Rectoris, Assistant Editor with Becker's ASD Review. We will begin today's webinar with a presentation. We will have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're really looking forward to hearing your questions. In a week following the webinar, we will send you all a copy of the presentation to the email you used to register. At this time, it is my pleasure to start today's webinar by introducing our presenter. Barbara Connell is the Vice President of Medical Affairs at Medline Industries in Northfield, Illinois. She earned her master's degree in healthcare administration from the University of St. Francis in Joliet, Illinois, and a Bachelor of Science degree in medical technology from Creighton University. She has more than 20 years experience as a medical technologist working at various levels of the lab, specifically in microbiology, infectious diseases, and hematology. She also has 15 years experience in the IVD laboratory diagnostics business. At Medline, Barbara is responsible for the clinical development and execution of Medline's infection prevention solutions. Barbara, I'm now going to turn the floor over to you.
Thank you, Mary, for that kind introduction. So, good afternoon, everyone, and I hope you're all enjoying this nice summer day, and I appreciate you coming in to spend an hour of time with us today to talk about how clean is clean, strategies for environmental cleanliness in the ambulatory setting. These are my disclosures. So let's get started. So I'm sure that you've all seen a slide similar to this in presentations before. And basically, a slide like this is used to depict the movement of patients through different types of healthcare services, generally from the community or ambulatory type of settings to the acute care hospital to the post-acute care facilities. And there's a lot of talk today about patients moving across what they call the continuum. But today we're not going to talk about healthcare across the continuum, but rather transmission of infections or organisms across the continuum. Now, it really used to be that when we talked about HAIs, we were talking about hospital-acquired infections. But, you know, that's not really the case anymore today. Every year, more and more healthcare episodes are being performed outside of the acute care facility. So we are now, more concerned about infections that can be acquired or transmitted outside of the hospitals. Our MDROs, or multiple drug-resistant organisms, and other virulent organisms, such as C. diff, were mainly found in the hospital setting, but now we're starting to find them more frequently outside of the hospital as either active infections or colonization. And you might be saying, oh, well, Barb, that's in the post-acute arena. And that's very true, but we need to be concerned about our ambulatory setting too, because organisms really don't see the boundaries of any particular type of facility, and nor do they like to remain inside so-called boxes that we put them in, such as acute care or post-acute care. They don't stop when the patient is discharged and jump off the patient and stay within the hospital, stay within the nursing facility. They really enjoy patients as a mode of transportation outside, so they get to enjoy this big, beautiful world too. It's something that we don't want, but it's a reality today that there's a lot of movement of these organisms. So with that being said, really all healthcare settings, regardless of the level of care provided, really must make infection prevention a true priority. So before we begin, let's just really talk a little bit about some of the foundational components of an infection prevention and control program. And this is for, regardless of setting, in any setting, you really have these three key components: hand hygiene, AMS stands for antimicrobial stewardship, and environmental cleaning and disinfection. And honestly, without robust programs in these three key foundational components, you're not going to have very good outcomes with your infection prevention program. You can add all the new novel products or processes and, you know, nifty little programs that you can do, but if you are not taking care of hand hygiene, if your physicians and your pharmacists and you infection preventionists out there aren't involved in antimicrobial stewardship, if you don't have a robust environmental cleaning and disinfection program, all of those other things that you're trying to do will be for naught. So I can't give a talk about going back to my microbiology roots and talking just a little bit about our bugs. They're somewhat near and dear to my heart. But I think you've probably seen this picture before too, maybe in a textbook, you know, a long time ago, but this is really your basic chain of infection. You start with an infectious agent at the top. There's a reservoir, there's a portal of exit where they get out and then they're transmitted. There's a portal of entry, there's that poor susceptible host, and the circle goes round and round and round. And although this is, you know, a picture that they use for a lot of scientific portrayals of the chain, I like to use this picture a little bit better because I think it hits home a little bit closer. So this particular model was presented by Kramer, and it was all the way back in 2006, but I think it still holds very true today, and it really shows the common modes of transmission. So up in the upper left-hand corner, you have your contaminated inanimate surfaces, and so when we talk about that, we're talking about bedside tables or bed rails or exam tables, those types of things. And those particular surfaces become contaminated and they can be a direct source of transmitted to your susceptible patient. But now, down on the bottom, you have the hands of healthcare workers. And the hands of healthcare workers are very busy, and they're busy doing a lot of different things and a lot of good work. But they're also very busy at times transmitting organisms too. And they're actually a very key component in that transmission circle or that chain of infection. Now, this is where your hand hygiene compliance really comes into play. So we know that in the past we've seen a lot of facilities, they would say, oh, you know, we have 90% compliance with our hand hygiene, or we're above 80%. And in fact, there was a Joint Commission standard at one time that even said, you know, you need to achieve greater than, I believe it was 80% hand hygiene compliance. So everyone was trying to achieve those goals, and they were posting these, you know, these numbers. And honestly, I think that hand hygiene compliance, that sometimes those numbers are the best example of fake news that we actually see today. Because when we look at it honestly, we probably really weren't achieving those great numbers with our hand hygiene compliance. And in fact, the Joint Commission did a large study, and not long ago, I believe they actually changed their standards so they don't even use a particular number anymore that you need to achieve. And what they say is that you must have a hand hygiene compliance program. You need to set the rate that you would like to achieve, and you must show momentum or improvement towards that rate. So they're not even saying anymore that you have to get to 90% or you have to get to 80%, although that would be, you know, our ultimate utopia. Honestly, there were some good papers that came out this year that did show some great hand hygiene compliance rates, and these were by folks who truly put their heart and souls into this, and they went on these long endeavors to improve their rates. So it is attainable, but it takes a lot of work. but we still should strive to get as high of hand hygiene compliance as possible. So in this, back to our diagram, so in this particular example, what they're saying is that if you have, if you have hand hygiene compliance of approximately 50% or less, you have an even greater potential for those great hands of your healthcare workers to be transmitting those organisms. This was a paper that was done by Dr. Bill Rotella, and he's one of the greats in environmental cleaning and disinfection. And in this paper that was published in ISHE in 2011, what he saw was that surface contamination and cross-transmission of MRSA and Clostridium difficile was generally around 28 to 58%. He also saw that cross-contamination via healthcare personnel's hands generally range from about 20 to 40%. And one of the things that really came out of this paper too that we need to be cognizant of is the fact that hospital patients, as well as other patients who can be colonized or who have just completed treatment for their pathogens, still continue to shed pathogens into their surrounding environment. So they know that patients who have completed their treatments with C. diff for a number of months after still shed those organisms. So just because you're done with your antibiotics or whatever treatment it was that you had doesn't mean that you don't have some shed of these organisms yet. And we also know that organisms persist on environmental surfaces for a number of days, even months, after they've been shed. Now, we've probably seen this chart before, and here's a list of some of our most common organisms, and there's some viruses on there too. And as you can see, our Acinetobacter, it can hang around from 3 days to 5 months. Clostridium difficile, the spores, they can remain for about 5 months. Pseudomonas, 6 hours to 16 months. And on dry floors, about 5 weeks. And there's also been some interesting studies that have been done looking at the floors of hospitals, but we always have to think about other healthcare related floors and how these organisms tend to persist. And our floor is really a mode of cross-contamination too. Another thing that's come out in the literature recently, this was a paper that was done by Mitchell, and it was published in the Journal of Hospital Infection. And there's a term that they've kind of coined called the room lotto. And in this paper, what they saw was that if you had a patient that was infected or colonized with a pathogen, whether it be C. diff, MRSA, BRE, Acinetobacter, etc., and that patient was in a particular room. And then the patient got better and they were discharged and the room was clean, disinfected, and the surfaces, and you did terminal clean on that room. But what they found was that even after the terminal cleaning, the surfaces in that room still remained contaminated with the pathogen. And so they followed the occupants who were put into that room after the patient who had the organisms. And what they found in this study was that if you're the next occupant in a room that had a patient with one of these pathogenic organisms, you had an increased risk of actually acquiring the pathogen. So, room lotto, are you going to get put in a room where someone else had one of these organisms? Another paper that was published within this year also saw that patients who were infected with these organisms and were given antibiotics, the next patient who came into the room had an increased risk of acquiring the pathogen. So environmental cleaning and disinfection really plays a large role in the transmission of these organisms. This was just another paper by Janet Haas, and her conclusion here was that there's a greater risk of infection with various drug-resistant organisms and C. diff for patients who are housed in previously occupied rooms by others with these organisms. So there's more and more research that is coming out showing that we really need to do a better job of our environmental cleaning. Okay, so much for the microbiology lesson today. Let's move on a little bit to talk about environmental cleanliness and patient satisfaction. So there was a study or a survey that was done of 1,000 patients by HEDA Research and Analytics, in which they asked patients to cite specific reasons for giving their provider a rating of a high level of satisfaction. So these were some of the comments that they put down with, on this survey. And these were things that if they saw these things within a provider, they felt like, oh, I'm very confident in this provider and I have a high degree of patient satisfaction. And some of these things, of course, are predictable: up-to-date medical equipment, quality of medical products, the time that the physician spends with a patient. But one of the things that was on there was a visible commitment to infection prevention. And what exactly does that mean? Well, what the people who surveyed said was that a visible commitment to infection prevention really meant that they saw people use hand sanitizers and other cleaning and sterilization products often, and that they were present and plentiful throughout the facility. So they saw their staff frequently washing their hands, especially before and after doing procedures or touching their patients. They gave masks to patients who needed them, maybe in the waiting room, and made them available to other people who wanted them. And they also said that they saw infection control signage and information present in the facility. And each area of the building was kept at exceedingly high standards of cleanliness. And they saw staff doing, and the patients saw staff doing cleaning and sterilization tasks. So all of these things really gave these patients a high degree of satisfaction and actually confidence in their providers. So you can see that many of these things focus around environmental cleanliness, such as the cleaning of the building. And so it's really important that these things are done. So when we look at this picture, I often ask, well, how clean is clean? And I think that this picture may look like your pre-op or your post-op days in your ambulatory surgery center, maybe even in a doctor's office if you put some walls up and change the bed for an exam table. It has pretty much the same type of equipment. But, if a patient, if I walked into this area and they said, Mrs. Connell, here's your gown, put your gown on, let's get going here. I would say, oh, well, I feel pretty good about this. This looks very clean. Maybe it even smells very clean. So I would be maybe more at ease and comfortable with my surroundings. Maybe if you were wheeled into the OR and you saw that it looked spick and span, very clean, and had that antiseptic smell and that smell of cleanliness, you may be more at ease and satisfied with your surroundings. But the problem is that appearances are just that, appearances. And microorganisms are not something that can be seen. So when we look at that same room, there are multiple places where organisms can be hanging out. And whether these are, normal type flora or if they're pathogenic organisms, those organisms are there. And I honestly believe that this is one of the problems why we can't get a handle on reducing the, reducing cross-contamination or the transmission of these organisms because we can't see them. So it's more or less, out of sight, out of mind, but they're there, and we need to be very much aware of them. And I'm sure you've all seen this picture here too about where these organisms can be lurking in a seemingly or an OR that is, truly looks clean. It can still harbor some nasty things. So we need to talk a little bit about some terms: cleaning, sterilization, and disinfection, and what does it really mean? Because you have to just like you have to understand the cycle of transmission or cross-contamination of organisms, you also have to understand what these terms mean. So cleaning and disinfection aren't the same thing. Cleaning means the removal of visible soil and organic contamination. And it requires physical action of scrubbing. You have to scrub with a surfactant or detergent and water. And it's the process that removes large numbers of organisms from surfaces and must always precede disinfection. So you always have to clean before you disinfect. And if you look at the picture of my healthcare worker there, and you can see that he's kind of scrubbing that mattress, and he's putting a little bit of elbow grease in that, and that's really great, and that's what you need to do. When you clean, you can't just kind of swipe over the surface because you're not removing that organic matter. And if you just swipe over the surface today, some remains, and tomorrow you swipe over the surface, more remains, and it builds up and it builds up until it's extremely difficult to get away with. So he's scrubbing, so that's great. But when you look at his cloth too, his cloth is pretty much open, and he's got his hand on top of it, and he's scrubbing that area. Now, more than likely, the next thing that will happen is he will pick that cloth up, and he will go to the next surface, and with the same surface, open surface of the cloth, he will start cleaning that surface. So you've still done some cross-contamination. When you clean, and also when you disinfect, you really need to use a folded cloth. And you need to fold the cloth in half and then in fourths, and then you can even fold it in eighths. And this works better when this is a live presentation, but you can see in this picture she's kind of got that cloth folded. And what you would do is you would still use that scrubbing action or that friction, but you would clean this bedside table with the one side of the cloth, and then you would move to another side of the cloth and clean the bed rail, and then move to another side of the cloth and clean, the next surface. And so that would help to reduce the transmission of those organisms, which is what we're trying to achieve. So you have to clean first. And then disinfection really is the process of eliminating or reducing harmful microorganisms from inanimate objects and surfaces. And generally, disinfection is done with a disinfectant, so a chemical or a product. Now, you can clean and disinfect at the same time, but if you have visible soil on an object, you really need to clean first and then go back and disinfect. And then, of course, sterilization is the process of killing all the microorganisms. And we're not really going to talk about that because we really can't achieve sterilization in our environment. That's really more targeted towards our instruments, so to speak. So this slide here, this was an example of the surveyor worksheet from CMS. And this is a great tool to use. Well, this is what they're going to use when they come in to survey your facility and to look at your infection prevention and control program, and of course, environmental infection control is part of that. But this particular survey and the CDC checklist for outpatient settings, and so this one not only focuses on the OR, but it also focuses on other areas of an ambulatory setting. Both of these checklists should actually be used in your risk assessment when you're looking at your infection prevention and control programs. And if you use these checklists and go around and say, okay, are we doing this? Are we doing this? It can help to identify gaps in your process and then help you to be more targeted with your focus on what you need to try to improve upon, for the next year. So these are good tools to have, and I have links to these at the end of the presentation too. Now, one of the other things I would just want to say about surveys is the fact that these days the surveyors are not just coming in and asking for your procedures. Of course, they want to see them, but they're not just going up to someone saying, well, how do you clean after a patient has left the pre-op area? They're saying, show me how you clean. So they're really starting to do direct observations of facility practices. So that's a very important thing to keep in mind, specifically when you're doing your education and training of the folks who are going to be doing your cleaning and disinfection in your facilities. And this is just kind of a summary of the things that they're looking for on the CMS survey and also that are listed on the CDC checklist. You have OR and procedure rooms cleaned and disinfected after each case. OR procedure rooms are terminally cleaned daily. High-touch surfaces and patient care areas, pre-op, post-op, exam rooms are cleaned between patients. You need to clean and disinfect when surfaces are contaminated, and everybody needs a procedure for gross spills of blood and body fluids, because unfortunately, even outside of the OR, sometimes those things happen. So let's talk a little bit about tools of the trade. And, you might say, well, Barb, when we do cleaning and disinfection in environmental services, we need a cleaner, we need a cloth, we need a mop, and maybe we need some germicidal wipes. And that's very true, but we need to consider what type of materials we're going to use, because it's very important. And if you don't provide the folks who are performing these procedures in your facilities with the right tools, that also can undermine your program. When we talk about cloths, cleaning cloths and mops, you want to consider the type of material that is used for those particular items. Today, microfiber is one of the materials that is touted as being one of the better materials to use. And it's really because it picks up the organic material much better than a cloth or cotton cloth would do. And it's really interesting. We don't have time today, but it's interesting if you look up the science of microfiber and how it actually works and how it grabs the dirt and picks it up. The other thing that's very good about microfiber is the fact that it is less likely to bind up the quaternary chemical in your disinfectant than a cotton cloth does. So with a cotton cloth, depending on what type of quaternary you're using, that cloth can actually bind the disinfectant, so essentially you're just cleaning with water and your product is no longer viable. So that's just a little bit about the cloths and the mops are the same thing. When we're looking for disinfectants, you always want to make sure that your disinfectants are hospital grade and that they're registered by the EPA. That's very important. One of the key things to look not only on your germicidal wipes, but also on your chemicals that you use is what bacteria, what organisms, I shouldn't say just bacteria, what organisms those particular germicidal wipes or chemicals will actually kill. Because not all germicidal wipes and chemicals are the same. And so it's very important to know what you want to kill and what products will actually take care of those organisms. We all know that C. diff spores are very hard. They're the hardest thing to kill, and that regular quaternary products won't do the job. And so you really need a bleach or possibly a hydrogen peroxide type of formula to kill those C. diff spores. So that needs to be, you need to detail that. A lot of places don't want to use bleach for everything. It's harsh and it can ruin surfaces and equipment. And so you end up with maybe 2 different cleaners. But if that's the case, you need to make sure that everyone who's going to use those cleaners are very educated about when and how to use each of them. So the other thing about our disinfectants is not only about what organisms that they'll kill, but also about these 3 things. Contact time. Contact time is the amount of time that the surface needs to remain wet in order for the organisms to be killed. So if the contact time is 3 minutes, then that surface has to remain wet for 3 minutes. So if you're using germicidal wipes and you use one wipe to clean a variety of surfaces, you're not only pushing those organisms around, but more than likely, you're not getting those surfaces wet enough to remain wet for their amount of time they need to kill the organisms. So it's important to understand that everybody understands what contact time means and how to do that. Dilution is an important thing too. When you're looking at products, you want to look at products that are ready to use or that are dispensed in pre-measured amounts over those that require mixing. What I can tell you is that I was working on an environmental services project actually last summer, and we couldn't figure out why we were monitoring the cleanliness of some of these rooms, and we were watching the EVS workers clean them, and why we couldn't get the ATP testing numbers down. Why it just wasn't working. We weren't getting the surfaces clean. Well, we did some investigation and we went back to the little machine that diluted their concentrated disinfectant, and we found out that the dilution machine was not working correctly, and essentially it was dispensing water. So they had been trying to clean these rooms with a cloth and water for we're not sure how long. So it's important to get these things that are easy to use and to make sure that they're being used correctly to monitor that. Other factors that you need to think about in disinfectant efficacy is the nature of the objects to be cleaned. What does your furniture look like? Is it material, cloth type material, or is it leather or faux leather, probably leather, maybe, which may be easier to wipe down and keep disinfected. Your bedside tables. And I know in an ambulatory setting, you may not have, a bedside table, but it's not, just think about those surfaces that you put in front of your patient. Are they just one continuous surface, Or do they have pullouts or drawers or other things that the patient is touching, nooks and crannies? Because if those nooks and crannies aren't being cleaned, your table or the whole item is not cleaned, and you still have a mode for transmission. Do you have pediatrics? Do you have a toy bin? What's in that toy bin? How do you clean them? I think the bane of all infection preventionists are stuffed animals. How do you clean them? How do you keep them from harboring those organisms? And then something else that you need to think about, especially here during the summer, is temperature and relative humidity. You need to know what the specifications are for your disinfectants, and do they work at certain temperatures and relative humidity, or do they need the humidity to work? Equipment disinfection, I think this is probably one of the biggest things that people have problems with. Is we think about all the different pieces of equipment that go from patient to patient or from room to room, etc. Now, I have the anesthesia machine there, and obviously we're not taking that from room to room, but that's probably the dirtiest piece of equipment in the OR. And what that really stems from is the fact that sometimes there's not really clear-cut rules as to who is supposed to clean that piece of equipment. And people get nervous about all the buttons and the levers, and they're afraid to touch it. And so if it's not really spelled out very clearly about whose responsibility that is to clean, then that can get overlooked. But things like stethoscopes and blood pressure cuffs, monitors, IV equipment, and blood glucose monitors, these all need to be cleaned and disinfected before they're used on the next patient. And, it's really important. And although I know that in the ambulatory setting, there's probably low risk of transmission of these pathogens, there's still a risk. And so we still need to be diligent about making sure that these things are taken care of. So one of the things that you need to remember is that you need to follow your manufacturer's instructions to the letter. During vendor training, make sure that they are following the IFU for cleaning and disinfecting of these pieces of equipment. And if the vendor is giving you instructions other than what's in the IFU, you need to ask for documentation as to why you should deviate, because you really need to do what it says in the IFU. So train to the IFU and not how Susie does it or how your sales rep does it if he deviates. The education needs to be instrument or device specific, and people should be able to demonstrate competency more than during the initial training of these things. And also, when you're looking at purchasing new mobile devices, so to speak, one of the first questions you need to ask is, how do you clean and disinfect this piece of equipment? And if it's a method that's totally outside of what you're currently doing, then maybe that instrument or piece of equipment isn't what you want in your facility, because the more you can standardize, the easier it is for your staff to be able to remember how to clean what with what. So who's responsible for cleaning? Is it environmental services, or is it nursing, or is it someone else? Maybe it's a contracted service. And I know that many of the ambulatory settings have contracted services that come in and do your cleaning. But what's most important is that, especially with all your mobile devices, we'll talk about those first, all your mobile devices, you need to clearly outline who is responsible for cleaning what. I was in one facility where they did this beautiful job. They took pictures of all their equipment. They had the glucose monitors and the blood pressure. They had pictures of all of them. Then they had what they were supposed to be cleaned with. how they were supposed to be cleaned. And they had it all laminated, and it was in this nice little book, and everybody was trained on it. And then the book was put in the IP's office, and that door was generally locked and not available to everyone. So that does not do anyone any good. So if you make beautiful tools like that, you need to keep them in a place that is accessible to everyone, because people forget. And so if they know, oh, it's right here, or it's on the cleaning cart, then they can go right to it. If you have a contracted service that comes in and does cleaning for you, maybe terminal cleaning at the end of the day, one of the things that's really important is to understand and know what they're doing. You know, what are they cleaning? How are they cleaning? Is it up to your standards? And maybe every once in a while you might want to pop in and do an observation of how they're cleaning, just to make sure that they're doing things the way you want them to. So with education and training, you need to train all responsible staff, your EVS and your nursing. If you have receptionists cleaning your reception areas or whatever, they need to be trained too. So with the task-specific training. And people should be trained when they're hired, and then they should have competencies later on, if not annually, every so often, so that they don't forget, and especially if you change products. And then when you do education and training, or you do observations of your employees, it's great to provide feedback. And if you're doing, direct observations, that's great, because you can provide real-time feedback. And I think that done correctly, that's always appreciated, because sometimes people just don't know, or they forget. So lastly, let's just talk a little bit about how to monitor cleanliness. So what is the measure for cleanliness? Well, there's no standard method for measuring the actual cleanliness of surfaces, the achievement of certain cleaning parameters, and defining, there's no real definition of the level of microbial contamination that correlates with good or poor environmental hygiene. So there's no standard measures out there, so what are we supposed to do? Well, there are some things that we can do to monitor. And so there are some cleaning verification systems out there, and these things have been well documented in the literature too. And although they're not necessarily organism specific or quantifiable for particular organisms, they do help to understand how well your cleaning and disinfection processes are working. Now, swab cultures are something that you probably would not do, because I don't think any of you in the ambulatory setting have a microbiology lab at hand. And even if you did, the micro lab, I can tell you, hates to do environmental cultures. And I can tell you that from experience. So really, environmental swabs may only be done maybe in an outbreak type of situation where you're trying to ID that particular organism. So fluorescent markers or ATP testing have been used pretty readily to monitor cleanliness. So with the fluorescent markers, it's really fairly inexpensive and pretty easy to do. What you would do is, before cleaning took place, you would go in and you'd put this fluorescent gel on the swab, and then you would mark certain areas within the area that you were observing with the gel. And then the person who's cleaning can't see this gel after you put it on. And so then they would go ahead and they would do their routine cleaning. And after they were gone, you would come with your handy dandy little black light, and you would look to see if they removed the entire fluorescent marker. Now you can see on the door on the right, they didn't do a very good job of cleaning that door handle, because there's still fluorescent gel on that handle. And in fact, You can see where they even contaminated the rest of the door because there's fluorescence that's now around the door handle when the gel was not put there originally, so it was moved. Excuse me. ATP systems, these are a little bit more sophisticated, and basically ATP systems measure light output, and it's really bioluminescence. So it's like the firefly reaction. I guess now's the time for fireflies, at least in the Midwest. But it's a combination of luciferin and luciferase with ATP that produces the light. And ATP is present in blood and skin cells and other bodily fluids and microbes. And as organic material comes into contact with surfaces, it's going to leave the ATP. And then after cleaning, the amount of ATP that remains is a direct indication of how much organic matter is still on the surface. So what you actually do is you have a special swab, you go in, you swab the surface, you put the swab in this reaction tube, you shake it up, and you put it in the luminometer and you get a reading. And the manufacturers each have their number, so to speak, that you want to be less than. And most of them are set at about 300. So if your swab comes in at less than 300 relative light units, you would say that that surface was cleaned effectively. What some places do is they'll start out with the 300, but as their cleaning staff gets to be pretty good about it, then they'll lower that number. And I've seen places that have actually used 250 or 200 as their standard number that they want to clean below. And it gets really competitive because people want to know their scores. Well, how did I do today? And if they exceeded the acceptable score, they want to go in and they want to re-clean it so that they can get below, so they can have a nice score. There are some. So you can never get rid of manual cleaning and disinfection. That will never go away. We will always have to manually clean and disinfect. But sometimes those processes aren't quite enough, and it's not really doing the whole trick. And so in the last, 5 to 10 years, so to speak, we've started to see no-touch room disinfecting systems, and really in the last 3 or 4 years, these systems are seen more prevalently in at least the acute care market. And I know for a physician's office or for a clinic, this is probably not something that you would come in contact with, but for an ambulatory surgery center, this might be something that your contracted services may want to provide as part of terminal cleaning in your ORs. Maybe if you have, if you're in an area that's endemic for MRSA or for another multiple drug resistant organism. And so this is why I'm showing this to you. And there's multiple different types. Usually they either use hydrogen peroxide or ultraviolet light. There's an article that was done by Otter et al. That was published in the Journal of Hospital Infection, and it gives nice key differences between the hydrogen peroxide and the UV light. And if you really want to know the details behind it all, this is a great paper that was done by Dr. John Boyce. And Dr. Boyce, once again, is one of those gurus of environmental cleaning and disinfection. And so he does a really nice overview of technologies that are out there for improving cleaning and disinfection of environmental surfaces. And it says hospitals here, but actually the things that he says, they do translate to the ambulatory setting too. So really, in summary, I think today we've learned that cross-transmission of organisms from environmental surfaces has been well documented in the literature. We know that patient satisfaction is impacted by a clean environment. We know that patient safety is impacted by environmental cleaning and disinfection. Education, training, and competency are really the key. People need to know what tools to, well, first off, you need to provide them with good tools to use They need to know what tools to use and when, how to use the tools, and who's responsible for cleaning what. It really comes down to that. And in some way, you need to monitor for cleanliness, at least every once in a while. So here are some resources that I've outlined that might help you with your environmental cleaning and disinfection program. The Guide to Infection Prevention in the Outpatient Setting by the CDC is a great document to have not only for environmental cleaning, but for other infection prevention and control practices. And here are some other guidelines for environmental cleaning that are often very useful. And I guess the last question that I have for today is, now, these two guys look clean, but the real question is, does swimming in the swimming pool in the summer, does that really take the place of routine bathing? You tell me. So thank you.
Thank you, Barbara, for that fantastic presentation. We're now going to start today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We will try to get through as many questions as we have time for. So Barbara, to start us off here, someone is saying, if you're looking to contract with an outside environmental cleaning service, what are some questions we should ask them about the services they provide?
That's a great question. And I think one of the big things that you need to do is you need to ask to see their procedures. What are your procedures for cleaning? And make sure that they match with what your expectations are. You also need to ask to see their training program. Look at their competency testing. See how often it's done. You might also want to ask, how do they monitor for cleanliness? If they use fluorescent gel or ATP, can you see that the performance of those monitors, from other facilities? Of course, they would probably mask those results. But I think that those are really key points. The other thing that you want to know about a contracted service is, do they clean healthcare facilities? Because if healthcare facility cleaning is not one of their core competencies, then that's something that you would need to really kind of investigate. You want to look at the cleaning products that they're using too, and make sure that they're all registered by the EPA. I think those are some. We could go on and on about that, but I think those are some of the big things that you'd want to ask.
Thank you, Barbara, for delving into those specifics. Someone else is wondering, is there a specific amount of time after a course of antibiotics is finished the patient shed? And how do you know when they are no longer considered infectious?
So that's the problem, because it really kind of depends on the organism. So they've seen shedding from patients with C. diff up to 3 to 4 months after they've been treated. So, once again, it's one of those things where we can't see the organism, so you just, you need to make sure that your cleaning and disinfection practices are appropriate. Now, I don't think I would equate the shedding with how long, if you're trying to get at how long do they need to be in contact precautions or whatever, that's a different situation. But they can shed into the environment for, a number of months after. But I can't say MRSA is this and C. diff is this and, Acinetobacter or something else.
Okay, thank you for that clarification, Barbara. Someone else is wondering, if you simply use a disposable wiper and achieve a 1-minute kill claim, is it still important to remove the microbes, or is it fine as long as they are dead?
Okay, so you still need to clean because you want to get that organic matter off the surface, so to speak, especially if you're monitoring with something like ATP. But, you know, I guess I'm not really understanding the question so much because, yeah, you want to kill it, but you also want to get the matter off the surface too.
Okay, that definitely makes sense.
I hope I interpreted that right.
I think so. We're going to move a little bit forward here, Barbara. So someone else is wondering, can you speak a little bit more to the effects of relative humidity and the effects of sterilized equipment?
Okay, so I was talking about, disinfection, not sterilization, okay? So we're talking about mobile devices like glucose monitors, blood pressure cuffs, and things like that. And what you just need to be aware of is you need to read the label on your products because they will generally state, or even in their product specifications or whatever, they may state at what temperature and humidity they're most effective at. And sometimes if you dig deep, they may say that, you know, if the humidity is greater than, you know, whatever, it may not be as effective as if the humidity is in a certain range. So that should be on the product's label, or at least in like their NIBS.
Great, thank you very much, Barbara. One more question here. So can you kind of speak a little bit more about the use of spray bottles when cleaning patient rooms?
Well, I know that that's not necessarily best practice when using the spray bottles. If you're talking about using a spray bottle and then like a cloth rather than using germicidal wipe, I think you would just, so the problem with that is really what kind of product are you using in the bottle? Is it something that you're mixing yourself? And if it needs to be diluted by the user or mixed by the user, then that's always an area that could potentially, you could have a failure there if the dilution wasn't done correctly. And so if you're using a spray bottle and a cloth, you'd want to make sure that you use, a ready-to-use type of cleaner. But I think practice has really moved more towards using the germicidal wipes or using an actual bucket and dipping your cloth in the bucket once and then cleaning only enough surfaces so that you can maintain that wet time, that contact time.
Great, thank you for clarifying that. And it seems that that is all the time we have for today. I want to thank Barbara for her excellent presentation and to our audience for participating today. Enjoy the remainder of your day, and we will look forward to having you for future webinars.